Hello, Robert Bastian here. We've embarked on a series to deal with the Integrative Diagnostic Model, the model that I developed maybe 35 years ago and have taught extensively, and so I just thought I would put it here on the internet. And today I want to talk about objections to the Integrative Diagnostic Model. These are things that people have said to me over the years to object. So I've taught this model. I've had brief visitors in the office, and they feel a little skeptical, or like it's a little too simple, or a little too Yoda-like or something. And so what have they said? So let's go through the list of objections. Number one, well, people say this is unique to you. You have these capabilities as a singer, and you can do things with your voice, and other people can't do that. That's unique to you. And my answer is no. I've taught it successfully to fellows and visitors. My two colleagues, my two partners, Dr. Brent Richardson and Dr. Rebecca Hosley, have mastered this model, and they are examples that say this isn't unique to me because I've taught it to them. There's also James Thomas. There's Norman Hogikian. There are any number of visitors who've come for a month to 3 months, whatever, that have at least begun to become quite acquainted with this model and pretty good at it. So it is not unique to me. Other people have said, well, it's too complicated. And my response to that is, well, any new skill or fund of knowledge takes a little work to master. Think about learning to drive a car. You have to learn where the turn signal is, and you have to learn to turn right and left, and you have to learn how to parallel park, and so forth. And it's pretty complicated. And once you master it, you just jump in the car and away you go. Also, use of a cell phone. A person who has no knowledge of a cell phone, you give them a cell phone. It's a little complicated at first, but once they get onto it, it's second nature. You just use it without even thinking. And I'm going to be teaching this model in a highly detailed, slow way. But once you master it, there are a lot of shortcuts. So, for example, the person that I just mentioned with the vibratory injury, I'm not going to go through in exhaustive detail all of the parts of the model that are potential. We have this large potential. I'm just going to go straight to the vocal overdoer syndrome, the swelling checks, and the very clear examination. So you do have shortcuts. Then there are people who say, well, you know, you're doing the vocal capability battery, and that should better be done by a speech pathologist. That's not a good use of the laryngologist's time. And I say, well, first of all, the time involved is not more than 2 minutes. It's less than 2 minutes. And then remember, I've called it the integrative model. So you're integrating the history, the vocal capability battery, and the laryngeal examination. You're trying to get those 3 arrows to point to one diagnosis. Well, if you have 2 of the arrows coming from the laryngologist, and then there's a 3rd arrow coming from the speech pathologist, well, they have to get together, or they have to read each other's reports, and there's too much lost in translation. It's too inefficient. The idea of integrating across 2 brains is just a highly second best kind of way of doing things. And again, one person, if possible, should master all 3 parts. Now, that doesn't mean there isn't a team, because you do need the speech pathologist for the voice therapy, or if the speech pathologist is mastering this entire model, you do need the laryngologist to do the vocal cord microsurgery. So it's not like there isn't a team, but the initial diagnosis should be done, in my opinion, if at all possible, by an individual. And then the other person on the team can verify and nuance and so forth. Then there's the objection, which I already kind of mentioned, that this is too time consuming. And I've said 30 minutes but that's the maximum. You really can work your way through this model quite quickly once you master it. And the alternative is to do that, splitting it between two people and then adding the objective measures, and now you're looking at 2 hours, all of the interruptions where the speech pathologist calls the doctor or the two are working together at the same time. It's so inefficient and time-consuming, and, by the way, very expensive. And then the last one is that it's too subjective. I have said many, many times that in modern medicine, measurement gets respect. Observation does not get respect. But remember, the scientific model is testing of hypotheses via observation or measurement. So it's embedded right in the scientific model is observation. And I would say that those who say it's too subjective, I would tell you that the integrative model is more objective than you think once you share a terminology with other people. In other words, is it subjective for two people to agree that that wall is green? I guess you could say that's subjective as compared with getting a photometer or a spectrometer of some sort to measure it and say, yes, it's green. Technology-driven model is much more subjective than you think. I had an experience in a voice laboratory one time where I demonstrated how I could make the output, the measurements, vary drastically simply by altering my production, my voice production. Not that much. I could just alter my voice production and the measurements were drastically different. I would also just bring out a conversation I overheard or I was part of where a person, and I'm exaggerating a little bit, in a group of voice people, this person said, there's nowhere that does more measures than we do. Like we do 50 measures of this and 20 measures of that. And the funny thing is, he said, sometimes you get measurements that look like, whoa, this is a really bad voice, but you listen to the voice and it's not that bad. And then there are other times when the measures are really good, but the voice sounds terrible. So I would say the technology-driven model, the objective measures are more subjective than you think. Okay, so was the basic point, was dealing with skepticism. Now, the next step, what we're going to go to next, is the history. So that'll be the next step. That's the part, what the patient tells you, what you learn from the patient. And so there are going to be a list of things that we're going to go through one by one, so that is next. And thank you for listening.